I'm going to talk about the development of an inhalable platelet-based therapy for lung injury, and luckily we just had a great introduction into lung injury in the previous talk, who spoke about ARDS. So acute lung injury is just, they fall under the same umbrella, but it's just the phase before ARDS. So it's rapid onset respiratory failure and is defined as acute inflammatory lung injury. And it can happen as a result of direct or indirect insults to the lung, and it is characterized by a loss of alveolar capillary barrier integrity. So when that barrier becomes disrupted, there's a lot of fluid influx into the lungs and pro-inflammatory cytokines into the lungs, and there's high levels of protein-rich pulmonary edema. Therefore, that leads to impaired gas exchange. And the important thing to note about the epidemiology as well was that patients who develop acute lung injury are already typically in hospital for another condition. So then they develop acute lung injury, they're put on ventilation, which is why they make up around 20 to 25% of mechanically ventilated patients in critical care units. And then they have a low chance of survival, with high morbidity rates of around 30 to 45%. And I've mentioned that they're put on ventilation. Some other common treatments include steroids or treating their underlying pathology. But the problem with this is that, firstly, ventilation is massively invasive. Steroids are immunosuppressive. And these treatments do not restore that alveolar capillary barrier integrity. So they're not stopping the protein-rich fluid influx. They're not reversing the lung damage. So we need a therapy that's going to target that mechanistic driver of acute lung injury. So our solution to this is platelets, which are small anucleate cells that travel in our blood. And I'm sure everyone here knows the roles of platelets in thrombosis and the blood clotting cascade. But I'm here to spread the news that platelets are very important immune cells. And they don't contain a nucleus, but they contain granules. And these granules are full of mediators and platelet growth factors and natural growth factors, which is how platelets contribute to not only their blood clotting roles, but also their roles in inflammation. So specifically in the lung, they can interact with endothelial cells to help seal small gaps in the capillary wall and provide like microplugs. They can interact with epithelial cells and help dampen down the severity of the inflammation and help clear that fluid from the lungs. And that's how they work to be anti-inflammatory and contribute to angiogenesis and cell proliferation, which we've heard a lot about immune cells being anti-inflammatory. We've heard about macrophages, but platelets are also involved in these processes. And they already circulate in our blood. They'll do this at the early phase of acute lung injury before things get out of hand with the alveolar capillary barrier. So by concentrating them outside of the body and then administering them to the lungs, we can amplify their response and increase their concentration in the lungs. So when I say a platelet-based therapy, what do I mean? It falls under the umbrella of regenerative medicine, which focuses on replacing or regenerating human cells or tissues so they go back to normal function. To produce platelet-rich plasma, blood is drawn from a patient, the same patient that will receive the therapy. It undergoes a centrifugation step, which separates the two layers of blood, and then the platelet-rich plasma is taken and used as a therapy. It has a high concentration of platelets and therefore the natural growth factors that I've spoken about. And it is currently used in clinics. It's used in several applications. It's just not used for the lung. So that's what I'll be explaining. To test the therapy, you need a model. So I'll explain how I have a model of acute lung injury, how I've introduced platelets into this model, and how I reduce the levels of lung injury, and how I'm exploring how we can actually develop this in humans. So I validated an in vivo model of acute lung injury using the American Thoracic Society guidelines, which were updated in 2022, and clearly state if you claim you have a model of acute lung injury, you need to show examples of these 4 measures that I've listed. So I use LPS at a dose of 5 mg per kg and administer via the intranasal route into my mice and then cull my mice 72 hours later. And I've shown the presence of an inflammatory response by showing increased levels of TNF-alpha, CXCL1, and neutrophils in the bowel fluid of these mice, showing histological evidence of tissue injury based on H&E analysis, and showing an increase in the lung injury score of these mice, and showing alteration of the alveolar capillary barrier, so that mechanistic driver of acute lung injury, and showing an increase in total protein concentration over the 72-hour period, and as a general health index, showing that the mice lose around 15% of their body weight over the 4 days. So I then introduced platelets into these mice as a therapy. So I used donor mice, and I collect their blood and isolate their platelets, and then administer the platelets into my experimental mice at a dose of 1 a day over the 4 days that I have my model. And we saw a significant decrease in the lung injury score in the mice that received multiple doses of platelets in comparison to the mice that didn't receive platelets. And it's just visualized here because the lung injury score is based on H&E analysis. We also saw a decrease in the levels of RAGE in the bowel of these mice. RAGE is a marker of epithelial damage, and increases in the levels of an XNA1 in the bowel of these mice. And XNA1 is a specialized pro-resolving mediator that comes into play during that resolution phase of inflammation. So showing that the lung environment with lower levels of RAGE and increased levels of an XNA1 is shifting towards repair. And then in this last graph here, I depleted platelets in my mice, and so that's the third and fourth and fifth column, but depleted platelets in the mice using an antibody. And then the mice got significant increases in their bowel hemorrhage. So that alveolar capillary barrier, when there was no platelets in the mice, was completely disrupted. They had a lot of protein rich fluid into their lungs, and blood was leaking into their lungs. And then in the final column, I reintroduced platelets into these mice. So after they were depleted and I gave the mice LPS, I gave them platelets, re-administration, and saw a significant decrease in their bowel hemorrhage. So showing how the effects that we were seeing are genuinely due to the platelet action, and that they are working to as barrier support for that alveolar capillary barrier. So after efficacy shown in vivo, I tried to see if we can actually nebulize a platelet-based therapy and if that has any effects on platelet function. So I take the platelet-rich plasma, and using an Aerogen Pro mesh nebulizer, nebulize it, collect anything that's been nebulized, and then run a couple of assays on that. And the assays are based on important platelet functions. So the images are just an F-actin stain, just so I can see the platelets, see if they remain intact. It seems that they do. And then the two main assays I've done is the chemotaxis assay and the aggregation assay. Chemotaxis assay because motility is a very important function of platelets in inflammation, because they move towards chemoattractants and inflammatory stimuli. So I've done this on two different platelet-based therapies. So isolated platelets, which are pure platelets, and platelet-rich plasma. And I've done it pre and post nebulization and compared their ability to move towards a chemoattractant. And it seems to be, their chemotactic activity seems to be maintained. And then the other assay I did was the aggregation assay, because obviously platelet aggregation is one of their main functions. And here I did see that their ability to aggregate significantly decreased post-nebulization. I think it's because there's less platelets in the formulation post-nebulization, so they're unable to aggregate. But this is still a safety advantage, because we wouldn't want to increase any risk of thrombosis or anything like that in the lung. So I've demonstrated that I had an in vivo model of acute lung injury, administered platelets into this model, and I showed some proof of efficacy, how platelets provide barrier support, they limit edema formation, and decrease the levels of inflammation. So this focuses on replacement therapy, administering platelet-rich plasma rather than depletion therapy, which is how a lot of anti-inflammatory agents work. So maybe this could be developed as a therapy targeting a mechanistic driver of acute lung injury, so that alveolar capillary barrier support. And then I looked at how the nebulization process affects the two main platelet functions, chemotactic activity, which was maintained, and aggregation, which was reduced. And I am now working on, I'm trying to reduce the number of animals I use in my mice. a number of mice I use in my studies. So I'm using ex vivo tools like precision cut lung slices to test the safety, efficacy, toxicity of different platelet-based therapies. And I'll continue to do so as I try to optimize formulation and delivery conditions to maximize function and ensure pulmonary safety. So thank you for listening.
Thanks, Anna. Well, very interesting talk. One question from me is, if this is going to be a treatment for the lung injury, would that be an autologous treatment, or it can be from other donors?
I think we would start by going autologous, just so the same patient that will receive the treatment, we would take their blood. It's typically how PRP is administered. I don't know what other safety issues would come into play if we're using other donors to administer, so we'd keep it same person.
Okay, thanks. So any question from the audience?
Yeah, sounds very interesting. Congratulations. So have you thought about aerosol delivery? Obviously you have, but then the animal study you did was instillation. Of course, you can get about 10-fold, 20-fold more drug or whatever substance you have with instillation. So have you kind of rethought, do you get enough platelets into the lung to make a difference?
If it was to be...
With aerosols, sorry.
Yeah, definitely a big question. I'm trying to get to that. I'm trying to find facilities where I can do a test like that, because I know there would be differences, but I don't know yet, but definitely.
Maybe we can help you with the delivery, so we're quite efficient with mouse aerosol delivery.
Thank you so much.
Yeah. Oh, sorry. Thank you. Excuse me. Thank you for the talk. Have you looked at the prophylactic delivery? Acute lung injury can be predicted, things like ischemic reperfusion and the likes. So have you looked at the protective potential of the platelets?
I have when I was testing different dosing regimes, and when I dosed platelets 4 hours before administering LPS, sorry, it wasn't 4 hours, it was 1 hour before administering LPS, there was also a decrease in the lung injury. I just haven't looked into that anymore because I didn't know if you can see when acute lung injury is developing, like early on. But that's interesting. I could look into that more. But they do.
Yeah, no, it's often a thing that people try to treat acute lung injury after it's established, or it is very predictable in some cases.
Yeah.
And I think kind of to echo Otmar's question, in terms of the dose, you get, mice are horrible. You get 1% of the dose on a good day by aerosol, probably more with some of Otmar's systems. But in terms of the human dose, it's not exactly a milligram per kilogram body weight dosing. Maybe it is, but it's the potency. Have you looked at things like preconditioning? So after you isolate the platelets, is there anything that you'd have identified that potentially makes them more potent?
Kind of. So the idea here is that when they are administered, the lung environment will cause them to activate and release their granules and their growth factors. But in terms of conditions, PRP is used, but a lot of times it's used as like platelet lysate. So it is activated. The PRP is activated, it forms a gel, and then you extract whatever comes out. So that is also one of the therapies I am looking at, and it seems to be the most, it's a bit tricky administering platelets, but if we can just administer all their good stuff, then that would be ideal. So when they do become activated with thrombin, for example, and then release all their contents, and then you take that.
Okay, I could ask 100 questions, but you see things like secretome, enriched secretome. You could use the platelets in some ways for that. But just to echo the last talk, the acute lung injury patient will be likely mechanically ventilated, if not immediately, very shortly afterwards. And things like oxygen, but also humidification of that patient circuit airway will be critical. Just be very careful that you do those experiments in a heated, humidified system like you would in a patient.
Okay.
Because some of those temperatures could get quite hot.
Of course, yeah.
But biologics, cells don't like to be cooked, as it turns out.
Yeah, they're very sensitive as well.
Thank you for that.
Thank
Really
you.
good talk.
I think we have one more question over there.
Just a quick question. I apologize if I missed it, but do you have any idea why the nebulization process might cause this reduction in aggregation? A hypothesis?
Yeah, I think that it's because there's less platelets post-nebulization, because a few of them get stuck on the mesh nebulizer. So I think that there's still a high concentration. It's still like 1 times 10 to the 8 platelets per mil. But before nebulization, it's like 1 times 10 to the 9 platelets per mil. So I think there's just not enough of them to aggregate.
Yes, thank you, I'm here. It was really interesting hearing about inhalable platelets. I guess many of us haven't heard about that before. My question is, you did mention the term heading towards repair. Do you think that would be after some doses, or is it continuous therapy? Do you think that would be a continuous therapy by the patient until the end of their lives, basically?
I don't think until the end of their lives, but for the duration that, I'm not sure to be fair, but maybe for the duration that they're in hospital, it may be like 1 dose a day. Well, I've done 1 dose a day in vivo. I don't know what that would look like in vivo, but it wouldn't just be 1 dose and then they're done. It would kind of be continued, but just until the lung injury kind of resolves.
Okay, so I think for the interest of time, maybe we will stop here. And once again, we thanks Anna.